Surgical Orthodontics. Contents: Introduction, Principles, Steps, Clinical Evaluation, Pre-surgical, STO, Mock surgery, Surgery and Post-surgical Orthodontics, Surgical methods and techniques, Correction of anteroposterior vertical transverse discrepancies, Genioplastic techniques and osteodistraction. The major surgical procedures: orthodontic surgeries, which deal with surgical correction of jaws, and facial, aesthetic or cosmetic surgeries like rhinoplasty, blepharoplasty, etc. Facial reconstruction surgeries like cleft lip and palate. Principles of orthodontic surgery: involves planned intentional fracturing of facial skeletal parts and repositioning them as desired in acceptable functional position. Can be done in maxilla as well as mandible. Indications: skeletal discrepancies, significant class 2 or class 3, facial imbalances or asymmetries which can cause gummy smile, limitations of tooth movements which need to keep teeth upright in bone, relapse potential of orthodontic treatment, excessive dental extrusion, expansion or tipping of teeth may not be stable. Steps in orthodontic surgery: clinical diagnosis and evaluation, interdisciplinary approach and pre-orthodontic dental care, pre-surgical orthodontics, which includes decompensation, STO, mock surgery, surgery and stabilization, post-surgical orthodontics and occlusal detailing and retention. Clinical diagnosis and evaluation: general medical and dental evaluation, which includes muscles and TMJ, socio-psychological evaluation, which includes the expectation of the patient about the treatment, the cephalometric evaluation, which includes Cox, quadrilateral analysis, Brodmann-Bolton template, Murray's mesh, radiographs, which includes OPG, SMV and hand-raised radio X-rays, photographs, modal analysis, and evaluation of TMJ and muscles of mastication. Epker's envelope of discrepancy: the maximum amount and range of movements possible by different treatment modalities, the inner envelope, the middle envelope and the outer envelope. The inner envelope includes the changes which occur only due to orthodontic treatment. Middle envelope includes the changes due to orthodontic treatment and growth modification as well. And outer envelope is the changes which occurs due to orthodontic surgery. The major surgical procedures: this is the Epker's modification of the envelope of discrepancy, wherein there are 4 envelopes. The 4th envelope includes skeletal anchorage as well. Pre-orthodontic dental care: any restoration perio problem has to be corrected before orthodontic or surgical correction. Objective is to maintain as many teeth as possible and stabilize the periodontium. The pre-surgical orthodontics: the aim is to position teeth to most desirable position over basal bone in preparation for intended surgery. The procedures undertaken are tooth alignment within arches, inter-arch coordination, incisor inclinations and decompensation. Decompensation or reverse orthodontics: the aim is to decompensate the changes. Extractions if done will be inverse of the normal protocol. Alignment of upper and lower teeth in class 2 and class 3 compensation. The decompensation of class 2 is by creating a positive overjet by preclination of the upper anteriors and retroclination of the lower anteriors, whereas in decompensation class 3 involves increasing the reverse overjet by uprighting the lower anteriors. The surgical treatment objective or STO, which is a prediction tracing: some degree of accuracy prediction can be made by cephalometric means. A 2D visual projection of changes in osseous, dental and soft tissues as a result of orthodontic and orthodontic surgical correction of dentofacial and occlusal deformity. Nowadays 3D digital and video imaging is also available. This is the STO tracing. The purpose of STO is to establish pre-surgical orthodontic goals, develop an accurate surgical objective that will achieve the best functional and aesthetic result, create a facial profile objective which can be used as a visual aid in consultation with the patient and family members. Mock surgery: using prediction tracing as a guide, surgical plan formulated, surgery is simulated on articulated working models, models cut and repositioned in desirable position and segments secured in new position with sticky wax, acrylic occlusal splints constructed in new position, helps in evaluation of treatment outcome and to know any possible modifications required in surgical treatment plan. This is a model or mock surgery being done on the cast. Surgery and stabilization. The step involves intentional or surgical fracturing and repositioning of bony fragments. Immobilization of bone fracture sites necessary for proper healing of bone. Pre-surgical splint fabrication. Intermaxillary fixation, which includes 6 to 8 weeks after which the splint is removed. With screws in place, immobilization period is greatly reduced. Now this is the intermaxillary fixation, and this is splint which is given. Post-surgical orthodontics, the final detailing of occlusion and aesthetic root paralleling is carried out. It takes usually about 4 to 6 months. The cases which are treated in surgical orthodontics are anteroposterior relations like class 1 BMP, class 2 and class 3 malocclusions. Vertical relationships include long face and anterior open bite. Transverse relationship as in skeletal cross bite and facial asymmetries. Craniofacial anomalies like cleft lip and palate, genioplasties and rhinoplasties. The team include an oral and maxillofacial surgeon, orthodontist, restorative dentist and a psychologist. Surgical procedures for correction of anteroposterior discrepancies, which includes maxillary surgeries moved in all 3 planes by Leaford 1. The maxilla is advanced and interposing grafts are placed. Anatomical skeletal restrictions for setback of maxilla as done so anterior segmental osteotomies. This is a Leaford 1 osteotomy and advancement for maxillary retrognathism. Leaford 1 down fracture for maxillary setback as well as superior repositioning for treatment of maxillary vertical excess type of cases. Maxillary anterior subapical osteotomy. This is done in case of anteroposterior excess without transverse and vertical excess. For descriptive purposes, the teeth are not shown in the occlusion. In mandibular surgeries includes BSSO, subapical osteotomy, inverted L osteotomy, C subapical osteotomy, transoral vertical oblique ramus osteotomy, and body osteotomies. Mandibular surgeries are the most versatile. One is the BSSO or advancement and reduction. Rigid internal fixation is easy, and the disadvantage is that paresthesia related to inferior alveolar nerve can occur. So this is the BSSO, wherein a section osteotomy of the body of the mandible is done, and the can be advanced as well as reduced depending on the malocclusion. Mandibular surgeries, inverted L osteotomy stabilization is difficult. C osteotomy, then the TOVRO has got less time than BSSO, and the disadvantage is extended jaw immobilization, and there will be difficulty in controlling condylar segments. So this is a vertical ramus osteotomy. So the mandibular surgeries for correction of class 2 skeletal malocclusions, which includes advancement of the mandible. So that's the sagittal split osteotomy, the C osteotomy, which depends on the shape of the cut. Then you have got inverted L osteotomy. Sagittal split osteotomy can also be used for setback of mandible in class 2 cases. Treatment of bimaxillary protrusion by maxillary and mandibular anterior segmental osteotomies. So these are certain cases which are treated with surgical orthodontics. The first one is a class 3 malocclusion along with a maxillary deficiency, which requires BSSO with a mandibular setback as well as a maxillary advancement. The second one is a bimax case. This is a class 3 case as well, where a reduction genioplasty is also done along with orthodontics. So the correction of vertical maxilla, this in case of skeletal open bite, Leaford 1 down fracture of maxilla with superior repositioning of maxilla in posterior region after removal of bone from lateral walls of nose, sinus and nasal septum. In deep bite cases, the maxilla is impacted after Leaford 1 surgery, which will include the vertical maxillary excess. So this is a vertical maxillary excess cases wherein a superior impacts of maxilla has been done, and a very good improvement in their gummy smile has been seen. Correction of vertical mandible. In case of skeletal open bite, ramal surgeries to rotate mandible anteriorly upwards and posteriorly downwards. It's a highly unstable surgery due to improper neuromuscular coordination of muscles. In case of deep bite, sagittal split mandibular ramus surgery to rotate the mandible slightly forward and down and gonial angle area up. The anterior subapical surgeries can also be performed. So these are the mandibular surgeries which are done for deep bite cases. Correction of transverse, maxilla can be expanded and constricted with reasonable stability. Constriction less than expansion. So mandible, the constriction is more easier than expansion. And maxillary surgeries for transverse discrepancies by segmenting the mandible in course of Leaford 1 round fracture. Expansion is done with parasagittal osteotomies in the lateral floor of nose or medial floor of sinus. A midline extension runs forward between roots of central incisors. The mandibular surgeries for transverse discrepancies includes movements in posterior region, which is limited by the condyle and lenoid relationship. Anterior region expansion is achieved by distraction osteogenesis. Genioplasty, these are all adjunctive procedures. We have got reduction genioplasty and advanced genioplasty, which can be done by grafts, silicone implants, porous, hydroxy, apatite, etc. Chin can be augmented by osteotomy of lower border of mandible to reposition symphysis or by adding implant material. A wedge-shaped portion of symphysis and inferior border is segmented. When it is advanced, it's called advanced genioplasty. Reduction genioplasty downgrafted to increase the lower anterior facial height, which can be shifted sideways to correct the asymmetry as well. So this is a genioplastic surgery, which the first one includes subapical osteotomy with advancing genioplasty. The next one is the reduction genioplasty. Next is the osteoindistraction, which Scotty Willard first published in 1905. Dr. Gabriel O. Elizarov modified and developed new ways of applying this technique of bone lengthening that uses body's natural healing mechanisms to generate new bone. Osteotomy is made in area external fixators used to slowly elongate bone to its new dimension, while natural ossification occurs in sites of distraction. So this is a case of asymmetry case where they have done distraction osteogenesis on the affected side, which helps in the lengthening of that side of the mandible. Application of distraction osteogenesis, which allows orthodontists to treat cases with a variety of anteroposterior and transverse problems, which was possible with surgery alone earlier. Lizaro's principles, which includes a latency period, there is a delay of 5 to 7 days for application of distraction forces should be there. The rate of distraction is 1 millimeter per day. Rhythm of distraction is 0.5 mm 2 times a day or 0.25 mm 4 times a day, but continuous force is ideal. Frame stability, capacity of fixator to hold new column of bone is stable enough. Post-surgical orthodontics, retention is the same as non-surgical. This is basically refinements of occlusion like vertical elastics for bite settling to override the proprioceptive impulses from the teeth. Surgical orthodontic treatment, there is a hierarchy of stability. So the more predictable and stable procedures are superior impaction of maxilla, then BSSO with advancement of mandible, chin in any direction. And the least stable ones are the mandibular setback, then down positioning of the maxilla, and expansion of maxilla. So that's all. Thank you.